So welcome to this webinar. We're just waiting for full attendees to join in. Apologies for starting a few minutes late, but we will get going just now. Okay, I think we have most people have joined us now. So thank you very much for joining us here today at London School of Hygiene, and a big welcome on behalf of the March Centre here at the London School of Hygiene and Tropical Medicine and the International Stillbirth Alliance to this webinar, Standing Up for Stillbirth. Every day, more than 5,000 women around the world endure the heartbreaking experience of stillbirth. Yet much can be done to prevent these tragedies and improve the care of affected women and families globally. Today, March and I are delighted to be joined by colleagues from UNICEF, the Gates Foundation, and academic institutions around the globe to review where we are currently for stillbirths and what can be done to stand up for stillbirths together. I would now like to welcome my colleague Lucia Hug from UNICEF's Division of Data Analytics Planning and Monitoring, who are responsible for the UN stillbirth and child mortality estimates, to provide an overview of the findings of the recent report Standing Up for Stillbirths on behalf of UNIGME. Thank you very much, Lucia. Over to you.
Thank you so much, Hannah, and thank you everybody for having me here to talk about the latest estimates on stillbirths. And I'm just going to start here so we have time to have the panel and the discussions later. So as Hannah said, I'm presenting the estimates of the UN IGME group for child mortality estimation, which consists of UNICEF and the World Health Organization, World Bank, and the United Nations Population Division. And we have a technical advisory group, the Core Stillbirth Estimation Group, that includes Hannah and other academics that really help us in producing these estimates. And our objectives are really to produce consistent estimates of stillbirth and child mortality, to monitor the progress worldwide, and also to improve the methods to estimate child mortality and stillbirths, and including data quality assessment and so forth. But also we work closely with countries to build capacities, increase capacities, produce timely estimates on child mortality and stillbirths. So that being said, I'm just going to jump here into the stillbirth data situation. So we currently produce stillbirth estimates for 200 countries. But as you can see here on the map, this shows the data points we have for stillbirth. And this is just the total number of stillbirths, the stillbirth rate. And you can see here that some countries have like a lot of bubbles, and if you see in green bubbles, these are data from registration systems, while we have in the lower and middle income countries, we have more household HMIS, so health management information system data. These are the orange data, and population-based studies, so they're not nationally representative, and a few household surveys. And we see quite a few countries where they have no bubbles, or if we look at, we can say 10% of the countries lack stillbirth data at all, and in 15% of the countries, they lack quality stillbirth data that are of poor quality, so they cannot be used to monitor stillbirths at the global level. And if you look a little bit at that, unfortunately, what we see is that the countries that account for a larger share of the stillbirths have much less data for stillbirth. So really the countries where we estimate the highest burden and regions, we have less data in these regions. Or if you look by income group, that would be similar. And well, this is a lot of information. We're just going to now look at the global level trends that we come up when we have these estimates. So currently we have 1.9 million stillbirths estimated for 2023. That is one stillbirth every 17 seconds, and this was 3.1 million in 2000, so there has been progress, but nevertheless the number is around 2 million since 2015 onwards, if we round it. And the risk of stillbirths is 14.3 in 2023. That means 1 in 70 births ends in a stillbirth. And there also has been progress made from 2022.6 in the year 2000. If we look at the country levels, we can see here that the highest stillbirth rates are concentrated in the regions of sub-Saharan Africa and Southern Asia. Those are the countries with the darker colors, and while we see the lighter colors in Europe and Western in Europe, and also in Northern America and Australia and New Zealand. And now if you look again here at the the burden of stillbirths, we can see that here, as I said, almost half of the stillbirths occur in sub-Saharan Africa globally, with 48%, and then we have another 30% in Southern Asia, while the other regions account for much less of the burden. And at the country level, we have 6 countries accounting for half of the burden. Of course, these are also populous countries, but also with higher stillbirth risks here. In terms of progress, as I said, we have seen progress in the stillbirth rates, and we can see that across all the regions. However, progress has, for instance, been much faster in Southern Asia compared to Sub-Saharan Africa. As you can see there, Southern Asia, Central and Southern Asia here, the yellow line has 15.5 stillbirths per 1,000, while in Sub-Saharan Africa, we still at 20.2 stillbirths per 1,000 total births. And so the stillbirth risk remains high, particularly in that region. In terms of timing, so whether the stillbirth occurs before or during labor, about half of the stillbirths occur during delivery. And that is at the global level, and across regions we find these proportions that differ. We have around 49% or half in Sub-Saharan Africa and Central Asia, while in Europe, Northern America, and Australia and New Zealand, it's only 12% that stillbirths that occur during labor and delivery. And this is a proportion of stillbirth that is highly preventable. And we can see over time this proportion has been declining, but nevertheless remains high in many regions. If you look at other risk factors, that's something what we did in a recent report we launched. If you look at household wealth, we can see that the poorest households have higher stillbirth rates than the wealthier households. Also, mothers with lower education levels or no education have higher risk of stillbirths. Similarly, in rural areas, the stillbirth risk is higher. And we also see that for maternally fertility-related conditions like birth interval or mother's age, like shorter birth intervals have a higher risk, and younger mothers and older mothers also have a higher stillbirth risk. In terms of progress, as we said, progress has been made, but progress has been much slower in stillbirth compared to other child mortality indicators. The neonatal mortality rate declined by 2.5% annually since 2000. And for the mortality rate among children aged 1 to 59 months, we saw a reduction of 3.8% per year, while the stillbirth rate was 2.0. And if you look at the periods like before the SDGs, or so in the period 2000 to 2015, the rate of progress was higher for stillbirths with 2.5, while now in the recent, since 2015, it's 1.1. So we see a slow, there's still progress, but this progress has slowed quite a lot to 1.1 rate of reduction for the recent period. And if you look at the regions here and we split by time, that's something that we observe in most of the regions, that progress has been slower, apart from Southern Asia, where progress has been remained at similar levels. And of course, progress also, it's not only the rate of progress, but also the level where we start on. But nevertheless, we see a slowing in the progress. Now, if you look at the projections for the future, we can say, and we have here the IVINA target that is set at 12 stillbirths or less by 2030 in each country. So it's a country level target. Every country should aim for that. We can see that a lot of countries have already achieved the target. That's the countries in very light gray, where we see 53 countries are at risk of missing the IVINA target. And these are the countries with the darker green, and 43 of these countries are in sub-Saharan Africa. And a lot of them will not, if they continue their current rates of progress, they will not meet the target by 2050, but much lower. So we really need to accelerate progress in these countries if we want them to meet the target in 5 years from now. So not much time is left here. And for some of them, that means that they really need to more than double their current rate, more than double or triple their current rates of progress. And what would that mean if we bend the curve is that we can save quite a lot of stillbirth life. And here we can see the projections here. The the 14.3 is the current rate. If we remain at the current level, because we have a concentration of stillbirths in sub-Saharan Africa and Southern Asia, we would actually see an increase in the number of stillbirths because we have an increasing number of births in the higher burden regions in projected. But if you continue current rate, if we manage to remain at the current level of rate of progress, we would have 1.7 million stillbirths in 2030. But if we meet the SDG, not the SDG, we need target in all the countries that are currently off track, by 2030, the annual number of stillbirths would drop to 1.2 million. The stillbirths in 2030, and even more if we look at high income countries, there the average stillbirth rate is 2.8. So if every country would be at the same level as high income, the group of high income countries, then we would only have 400,000 stillbirths in 2030. So really here bending the curve would save a lot of births and prevent stillbirths. So we have all the, we just launched, we launched a report actually in April, and you can access the report on childmortality.org. And we also have here the data for each of the countries, and the underlying data to come up with the estimates, but also the report and other profiles for each country that you can visit there. I'm going to pause here. I have a few more slides if you want about the methods and the definition, but maybe we can come back to that later.
Thank you very much, Lucia, for sharing those slides and an overview of the report, the Stillbirth report, and lots of the data. And we can see progress. We can see some things going well, some things slower. What we'd really love to do now is spend some time thinking about, well, what do we do? How do we bend that curve that Lucia's talking about, not just for the population level numbers, but for the individual women and families affected as well? So now I'd like to hand over to Professor Rakhi Dandona from the Public Health Foundation India and International Stillbirth Alliance, who's going to be introducing our panelists and moderating the next session. So over to you, Rakhi.
Thank you, Hannah. Thank you very much. Pleased to be here. Thank you, Lucia, for that excellent summary of the long way ahead for us to address stillbirth prevention and to support mothers and families who endure the heartbreaking experience of stillbirth. Welcome everyone who's joined us today for this webinar, Standing Up for Stillbirth. We will explore what this means practically in terms of practical actions with our panel today. The panel includes Lucia from UNICEF, we just heard from her, Nonkululeko Shubula, who is a bereaved parent from South Africa and is also a board member of the ISA. We have Dr. Hema Magee from Gates Foundation, Dr. Tracy Mills from Liverpool School of Tropical Medicine, Professor Elizabeth McClure from RTI International, and Dr. Sarah Saleem from Aga Khan University, Pakistan. Welcome to you all. Thank you for agreeing to be part of this panel today. If I could request you to please keep your response to less than 2 minutes for each question, that would be awesome for us to, complete the questions that we have for all of you. Thank you so much. Let's start with Lucia. Lucia, clearly data are critical to determine what the burden, how do we target interventions, and of course, how do we target progress. And yet you continue to show us that the availability of data on stillbirths remains poor. One would have hoped to see a big change from the last report to this report in terms of availability. Can you elaborate for us? What does better data or better availability mean in practice to you?
Thank you, Rakhi. Sorry. Now, I think we have seen some improvements actually. It's smaller steps, but we have seen quite some improvement. And I think with stillbirths also, I think Hannah has been a tremendous job there in really making clear what is a stillbirth. So if we don't have a clear definition, it also becomes very challenging to have good data on that. And we have a much better classification now than we used to have with the ICD-11 that used the gestational age. And we have this as the criteria to define stillbirths, and we look at 22 weeks at the national level and 28 weeks for international comparison. So that has been a very first step to make it easier also to be sure we compare the same thing and we collect the same data. And countries have been responsive to that. But nevertheless, there's still a lot of communication that needs to happen there, that countries are aware of these definitions and how to record stillbirths and what data we need actually in order to monitor it and to make sure that we compare the same things across countries or within a country, also between facilities and so forth. Because without understanding also differences in the data, we might compare different things and not understand where the problems are. But I think here also really like the health system can support us in collecting data, because a lot of births occur in facility. So the health system can help to record these stillbirths and inform and publish these data. Because one step is, of course, to record the stillbirths, but then another step is also to make this data available for practitioners, for policymakers, and also for us to monitor it more at the global level. And of course, I mean, there's different sources we can use for stillbirth data, and also if we can address different questions with different data. So from surveys, we can learn more about risk factors that we can from an administrative system, for instance. But we can also, and if the survey, and I think it was great with the DHS that they included the full pregnancy histories, collecting information not only in every live birth, but on every birth. So that was also a good step. Of course, now this is in danger because the program is currently not continuing like it did in the past. But it was a great step, and a lot of people here have been contributing to include that in the household surveys. And of course, then there's the registries that can be strengthened to ensure that stillbirths are recorded in the registries, and also in studies, like some of the studies only collect information on live births and live birth outcomes of pregnancies, but it's really important also to collect the information on stillbirths. So these are a few things, and I think also I think it's good if you continue to bring the issue up to raise the importance of it, so that improves also the interest in countries to collect data or report data on stillbirths. Thank you.
Thank you, Lucia. So clearly diverse sources and standardization of definitions is important as we continue to have global comparison and these estimates. Thank you for that. Beth, if I could come to you. What does standing up for stillbirth mean to you as a researcher? What more research is needed to accelerate the progress as described by the report?
Thank you so much. I was just to emphasize what Lucia said. Having the standardized data really is critical for all research. And I think, as she mentioned, we're really getting better at that, but continuing that progress, and especially I think in light of the funding cuts that we're all facing, is really going to be critical going forward. So standardizing the definitions, and as you saw just a few minutes ago, especially in the lowest resource areas, sub-Saharan Africa, areas of Asia, is really critical. We did see most of the stillbirths are considered stillbirths that happen around labor and delivery and considered preventable. So again, understanding research into how we can reduce those stillbirths in efficient, cost-effective ways, and again, especially in areas where we have the least resources, is critical, and probably a way that we can hopefully move the needle, especially in sub-Saharan Africa. We do know that even with some of the intrapartum stillbirths, there may be additional risk factors. And there's some promising research around biomarkers to look at placental risk factors, other maternal risk factors, and even some AI technology that is being studied right now to see if we can identify signs of maternal hypertension early in pregnancy through low-cost devices. So I think there's some promising tools that can help, again, especially in low resource areas where we may be challenged with the number of healthcare providers available. And hopefully those can be accelerated to help have an impact in especially sub-Saharan Africa settings. And then finally, my colleague Sarah will talk a little bit about this in a moment, but we have had some interesting research in Asia that she's led, but she really wanted to emphasize that research to help impact and galvanize support from to inform public health policy and get support from government actions is really important. So thinking about how research translates to public policy is critical. So thank you very much, and look forward to the discussion.
Thank you, Beth. Sarah, if I could come to you, our understanding of causes of stillbirth in developing settings continues to remain poor. Can you please elaborate for us what is being done to improve this understanding for causes of stillbirth? Thank you.
I have to unmute myself before. Thank you very much. See, I think for last 2 decades, much has been done, and that has brought the attention of global health experts and the donor agencies on the issue of stillbirth and perinatal mortality. And we have discussed about initiatives like EWNE and Newborn Action Plan and all, etc. That has really helped a lot, and SDGs have really adopted the goals for the EWNE, we can call it now. So, and also I am very appreciative of the Lancet series, which has published lots of research, very hard research and very important research highlighting the causes and also the drivers leading to stillbirth. So that has added to the knowledge a lot, but still a lot has to be done, because we can see that still, I mean, as we have heard Lucia talking about, that interpartum mortality is still very high, of fetal mortality is still very high, though all the interventions are there, but especially for low resource countries, having the high-tech technology available to everyone is not possible, and we have to find out ways how this can be done, and look into the drivers of mitigating those impact. And like what Beth mentioned about our study on looking at the causes of stillbirths, we looked very comprehensively. We looked at the placental, fetal, and maternal causes and analyzed and compiled together. And we find out that the stillbirths were caused by fetal asphyxia, and this is often preceded by placental malperfusion and clinically associated with preeclampsia, placental disruption, and small for gestational age babies. And this happened also, part of our study sample was also the preterm babies who died later. So they were, again, the causes were more sort of, again, preceded by the birth asphyxia, and then, of course, by the infection. And we also found, not very surprisingly for LMICs, that some of the babies, and through MITS, minimal invasive tissue sampling, we did some tests on PCR and also the placental pathology. And we found the organisms in the tissues also of the babies, and those were nosocomial infection. So that is one of, again, the factor which can be prevented, and it's dangerous for the babies who are admitted in ICU, NICUs, at the in LMICs, resource poor countries. The other thing which we need to look at are the socioeconomic determinants or factors, which may call these as the intermediate or distant factors. That is what Lisa mentioned about the education status, about the poverty, rural lodging, residency, all those things. We have to think that if we cannot bring rapidly change these things, then what should be the interventions which can really help these women in reducing these things. But after having all these things, the important thing is that any action we take to help mothers to have a healthy baby will definitely prevent perinatal mortality, stillbirths, and also neonatal mortality. So it's still lots have to be done, lots have been done, lots have to be done. Thank you.
Thank you, Sarah. And I will circle back on interventions with Hema, but I do want to go to Nonku first. Nonku, we heard one baby is stillborn every 17 seconds, which means that 1 hour of this webinar that all of us are on, about 200 babies would be stillborn during this webinar. I want to come to you. What do you think when you hear these numbers? Do these reflect the urgency in action to you? Nanku? maybe she's having some trouble with her connection. So maybe I could go to Hema and come. Oh, yeah, you're there.
Hello.
Yes, Nanku, over to you.
Yes. Can you repeat the question for me, please?
Yeah, I was just saying that, during this 1 hour of webinar, an estimated 200 babies would be stillborn. And I wanted to ask you, what these numbers reflect to you. What kind of urgency do you think is needed in action?
Thank you so much for the question. As a parent who has experienced stillbirth, these numbers are not just statistics. They represent millions of families that are facing unimaginable grief as well as loss. So I would say better support will actually mean having a holistic approach from compassionate care and healthcare providers who are actually trained to handle these delicate situations with huge empathy, as well as campaigns to reduce stigma as well as isolation, and access to mental health care, such as peer support and practical resources that must be a part of standard care everywhere, as well as policy implementations. Thank you. Over.
Thank you, Nanku, for that. Yes, of course, the holistic approach is needed. That also includes bereavement care, and we will touch upon that with Tracy and you a little later. I don't want to go to Hema now. Hema, we heard about the urgency to get to 2030. We also heard from Lucia and Sarah that, the stillbirths that occur during intrapartum, during labor are mostly preventable, and there are interventions available to save the babies. Then what does this acceleration actually mean? How do we make sure that stillbirth prevention is actually integrated well within the maternal newborn programs?
Thank you, Raki, and thank you for the opportunity to be on this important panel discussion. I think this is it's strange. It feels like we shouldn't even have to talk about it, right? Because it feels like it's so obvious that women deserve high quality care during pregnancy and during delivery, yet the fact that they don't is the whole reason we have to talk about it and shout about it, to be frank, right? So I think that the interventions are very well known on how to prevent stillbirths. Obviously, there's still room for innovation, and our colleagues have spoken to some of the areas that are in the discovery phase, some of the innovations on the preeclampsia side, and placental pathology side. And at the same time, we also know that at least half of these stillbirths are happening during intrapartum period and absolutely could be preventable with high quality, right place, right time care. And we have critical and often not too complicated interventions that can be done through strong antenatal care to help prevent stillbirths. So just kind of walking through that if antenatal care platforms are strengthened and made patient-friendly, woman-friendly, and accessible to women such that they want to seek it so that they get something of value, things like having point-of-care ultrasound, detecting heartbeat, assessing fetal health early, multiple micronutrient supplementation, or otherwise known as comprehensive prenatal vitamins, extremely high impact in a number of outcomes, including stillbirth prevention, management and detection and management of infections, including syphilis, but also others. All of these are kind of very standard of care, and typically in protocol interventions in many countries. Some are still on the pathway, like MMS, and making ultrasounds accessible, but these are areas that we're really focusing on. But I think what's critical is to not just end with the things or the interventions, but to use that as an entry point to bring policymakers, clinical providers, and patients together at the table so that the whole platform is strengthened as part of the health system. And then as you get into delivery time, obviously, then once, that same woman has to be able to know where to go for a safe birth and be managed and have her labor be monitored with intrapartum monitoring, fetal distress detected and managed promptly. The fact that half of these babies are dying intrapartum, that there is no difference between those stillbirths and the baby who dies 2 minutes after birth. These are all newborn deaths. And of course, they all count equally, but this distinction sometimes has contributed to that invisibility, so to speak, of these babies. And so I think in those ways, the interventions required to prevent stillbirths is very much anchored and integrated into the care for the maternal and newborn care dyad. And if we can really center on focusing for high quality woman-centered care, then we should be able to make a very significant dent in stillbirth prevention. And I'm sorry, just one more thing is I want to add that I think equally paired with this is really focusing also on increasing awareness that stillbirths are preventable. I mean, we've encountered a similar thing in the preterm amongst preterm low birth weight, small and sick babies. That in many communities, these are the thought is that this just happens, that there's nothing you can do about it. It's something that perhaps is that we should hide or keep to ourselves. And obviously these are all different and nuanced situations, but they're all kind of part of a same spectrum of blaming women of this sort of misogyny that's fairly embedded into society. And I think as a system, we can do much better to improve, educate, and break those barriers. So the more that communities themselves also know that stillbirths are preventable, that these are the things that you should have access to in your care, these are likely to prevent stillbirths, that also goes a long way towards preventing stillbirths. Thanks.
Thank you, Hema, for this excellent perspective on the continuum from antenatal care all the way to, of course, dealing with the impressions that we have that stillbirths cannot be prevented. And I'm so pleased that you did raise, antenatal care and the quality of antenatal care as a big piece that's kind of missing in the conversation. And so thank you for bringing that in. We've seen a lot of work on increasing or improving the coverage of ANC visits, but we really haven't seen enough work in improving the quality at every visit. So thank you for bringing attention to that. There's a chapter in the UN IGMI report that documents accounts of loss, grief, and healing by bereaved mothers from around the world. It's titled "A Need to Grieve, a Right to be Honored." It calls for compassionate bereavement care. Tracy, if I could come to you, can you please elaborate on work that's currently underway to improve the care given to the affected women and families?
Thank you very much. Yeah, so this is really important, isn't it? So that we ensure that there's equitable access to respectful and compassionate bereavement support for all women. And this certainly isn't happening in many places around the world. So our global health unit has a major work stream which focuses on trying to build the evidence base for effective bereavement care pathways. And I think that's been an area where there has not been enough research and there's not been enough evaluation and sharing of experiences across the world, really. So what we're trying to do is, our partnership includes countries in sub-Saharan Africa and South Asia. And we take the approach that it's really important to work with both our local partners, women and families, and health workers all come together to tackle this problem. So we very much start off with exploring needs to understand, what the gaps are in services, and also to understand the local culture and, what's happening around support. And that's really important because although we can learn from what's happening in different settings, we can't import directly one intervention from one context to another. We really need to make them fit to the context they're going to be implemented. So then we've done a lot of work around developing interventions based on the understanding we've got, working with local communities, testing their feasibility, and then moving on to large scale evaluations, because we really need, this is, several people have mentioned the importance of having evidence to put before policymakers and say this really makes a difference. So if we're not evaluating things, we're never going to know that. So at the moment, and if you look in the literature, there's an absolute lack of evaluation of bereavement care interventions globally. So at the moment, we're conducting a large step wedge cluster randomized controlled trial in Kenya and Uganda, where we've implemented both facility-based interventions to improve health worker education and the environment for support in facilities, and peer support in the community. Somebody else mentioned peer support, and I think that's really, really important. So that's in Kenya and Uganda. We're also doing earlier stage work in India and Pakistan. And I think, one thing I have learned from working in this area is actually, as human beings, there's an awful lot more that unites us. The experiences that women tell us are very, there's a lot of shared experiences. And it's all about, I think, balance, isn't it? So learning where we can across different settings, talking in meetings like this, and then you can use those approaches to integrate sort of cultural conceptions and practices where they're helpful, and then also challenge those that are not helpful to parents, but let parents tell you what's the most important thing to them. But the most important thing, I think, is we evaluate, we write up the findings, we share, and we keep talking about it, and that's where we're going to make progress.
Thank you so much, Tracy, and we look forward to those findings and learning from those. Clearly a major gap that's been identified. Nonco, if I can come to you, what do you think, what more is needed to support parents better?
Thank you so much for the question, Raki. So in terms of acceleration, what would parents need is campaigns, public campaigns, especially health campaigns, to raise awareness in terms of reducing stigma. There's a lot of stigma, especially in Africa, surrounding stillbirth. A fostered community support approach. Acceleration, that actually means turning awareness into action. So supporting those of us who already have experienced loss, so that we can implement situations or implement supports such as peer support amongst other parents. Bereavement care is also not really a thing. It's marginalized here in Africa. So bereavement care programs as well, that'll be something that parents would actually need. Thank you.
Thank you, Nonco. We've heard so far from the panelists, the actions that we need to improve data, to accelerate progress in prevention, and to improve care. But the next important question is, where does the money come from? Hema, if this question could go to you, in this landscape of funding that we have currently, how best do you think we can find funds, leverage funds for all actions that we have discussed here today?
Yeah, thank you. Of course, we know the situation is very difficult. At the same time, in a strange way, the MNCH world has never had verticalized funding. And so the ODA cuts, while of course they impact the whole system, the direct and most kind of clear direct impacts right now are primarily around the areas that have received a lot of vertical funding, like HIV, TB, and malaria. So while this is obviously a shock and a huge injustice for countries all over the world, if we, at the same time, given that it is what it is, we have to use this as an opportunity to use this for redesign. So in that way, what I mean is that a strange thing is that while the the funding has reduced. What has also potentially reduced is some of the fragmentation that a lot of the vertical funding streams had inadvertently created. So with that comes the opportunity to really kind of augment the narrative and the opportunity that maternal newborn child health kind of platforms through a strengthened PHC primary healthcare system provide for being able to provide woman-centered, person-centered, integrated primary care. And so that means that rather than looking at it as this, like this malaria program, this HIV program, this MNCH program, or even within that maternal program, stillbirth program, newborn program, that we have the opportunity to really look at the kind of district or the subnational unit of the health system and the network of care required, and really try to build out the opportunities that a lot of the what are traditionally thought of as MNCH platforms play for strengthening all of the care delivery systems. So for example, something that we're encountering quite a bit as in our work with a number of country governments in trying to very live reprioritize, move things around, and try to use data to focus on data-driven interventions to drive acceleration, drive impact. If you think about a woman in a pregnant woman, let's say, and in a malaria endemic country, that same woman who is at risk for malaria, if she gets malaria, then is at higher risk for anemia, higher risk for PPH, higher risk for preterm birth. And so in a way, trying to think of that that it's, if you design for the woman, all of these programs can be integrated in a high quality way and gain a lot of efficiencies. And then with that is really comes the opportunity for service delivery innovations to make care better quality and cheaper and closer and closer to being in the hands of women themselves, or as close as possible. So I think that we have to be creative, we have to be nimble, we also have to do things differently ourselves. We cannot create a new version of fragmentation with different donors still pushing different interests. And so I think it's a real, it's both it's an incredible opportunity if we take it seriously and do the really hard work of listening to governments carefully, listening to patients and people carefully, and leveraging data to help inform that process in a structured way.
Thank you. Thank you. Well said. I think we really need to be creative and we can redesign, we shouldn't lose on this opportunity to accelerate the progress as we think is important. Thank you. This brings us to the end of the panel discussion. Thank you so much to all of you for sharing your perspectives. And I think as Nanku said, acceleration to her means turning knowledge into action. And all of us have heard about the potential actions that we can take in our settings. With this now, I'll hand over to Paula quickly, who is the chair of ISA, for her closing remarks.
I think we're going to do a few questions first.
We've got still 10 minutes left. Sorry. Yes, Hannah, over to you.
Yeah, no, that's fine. There's a few questions. So, and if it's okay, Raki, I'll see if any questions in the room first, and then I'll hand back to you, Paula, for finish in a minute. So are there any questions in the room for any of our panelists? So if you can just introduce yourself very briefly, your name and then the question.
Hi, everyone. My name's Coleman. Thank you so much, everyone, for talking and sharing your information so far. I did have a question for Tracy. I was listening about how you comment on the importance of taking a cultural relative approach to treatment. How might that differ between cultures to be most effective?
So I was talking about bereavement care really, rather than treatment as such. So what I'm saying is I think we need to be very careful when we're thinking about strategies to improve care, that we're not just trying to import something that's been developed and works in one place to somewhere else. And we really need to understand the context the, you know, what people in that setting perceive as the issues and the gaps in services, and also think about the delivery of healthcare and communities, and make sure that things that we think might work are developed appropriately and then tested and evaluated, because there's been a lot of examples of where things have just been imported and we assume, you know, it's worked in this setting, it's going to work somewhere else, and it doesn't always.
Thank you, Tracy. Any other questions in the room? Okay, Raki, I'll hand back over to you then if there are other questions you want to take from the Q&A.
Thank you, Hannah. We have time for a couple of questions. I'm going to take this question from Dr. Linda. I wanted to hear. It's about, you know, talking about improving male engagement and involvement of males in prevention efforts to address cultural issues. Tracy, did you want to take this?
Yeah. So I think that's a really good point, and it's really important. So in many of the settings that we work in, so apart from bereavement care, in all access to healthcare, men are very important in sometimes controlling that access and dictating to women what they can and can't do. Also, after a stillbirth or a neonatal death, fathers have needs as well as mothers, and are, you know, from our qualitative research, we've seen that fathers are you know, affected very profoundly, don't always find it easy to communicate those effects because of how society expects fathers to behave. But so, you know, you need to look at this in the round, don't you, and include everybody within the family unit. And it's not just fathers, is it? It can be mothers, mother-in-laws, you know, the whole family are impacted by these tragic events. So you really have to include everybody's perspective in that and try and give support where it's important. Yeah.
Thank you, Tracy. Nanku, did you want to comment on this? Nanku? All right, maybe we'll go to the next one. There's one from Dr. Sabir, who's raised the point of misreporting or misclassification between neonatal death and stillbirths within the facility data. And he's highlighted that this misclassification or misreporting could be intentional or could also provide a gap in understanding of stillbirth definition. Lucia, if I could bring this question to you. How do you think this can be sorted, and how do you manage this within the data that you have?
Thank you, Raki. So you're talking about the misclassification between stillbirth and early neonatal deaths, is that correct?
Yes. Yes.
So I mean, of course, that for very early neonatal deaths, so stillbirth is sometimes really for the health care provider to make that classification known. Sometimes at these very early, it's challenging, but nevertheless, in the health records, there are different. Like there's if that's not properly recorded, there is a clear definition on the signs of life, whether the baby is breathing or not. So these things can be strengthened in the system. In general, we try to. I mean, overall, I mean it's challenging because it goes both ways. The misclassification of some baby might be classified as neonatal death while it was a stillbirth on the other way around. So it's not only one way, but nevertheless, and it's particularly challenging in those early deaths. And it has sometimes, there's different investigations that happen depending on the outcome of the pregnancy. So there might be some incentives why to classify a baby that has passed as neonatal or as stillbirth. And so it's really, but we need to work closely with the health practitioners to improve the recording there to make sure that they get classified correctly. In general, we look at the ratio. Sorry, I see somebody has the hand up.
Yeah, I think Emma does.
Yeah, no, sorry, Lucia, if you have more to say, I was just going to build on your response.
Okay. But in general, we look at the ratios of stillbirth to neonatal, but of course, we also have to keep in mind there, what is the stillbirth 22 weeks or 28 weeks, so that ratio can differ by that. But and sometimes we also can look at the perinatal mortality rate in overall, if that to see what progress has been made and so forth. But it is very challenging, particular at these early deaths, to get it right.
Thank you.
Thank you.
Hema, did you want to add?
Yeah, I was just going to add that I think perhaps the question also sort of hints at the aspect of the culture around in the health system and amongst providers around how stillbirths may be perceived versus how a newborn death might be received. And very much have had quite a bit of experience with this myself, and in the kind of health system quality of world as in the programmatic efforts that have been involved in. And it's very interesting. I mean, it is telling in and of itself that somehow a stillbirth is quote better than a neonatal death. I think often that's when they just all get called macerated regardless, because the perception is that then it wasn't preventable. And I think a lot of that has to do with a lack of a culture of quality and a culture of joint accountability for things that are fundamentally have drivers that are multifaceted and occur across many different time points and different levels of care. Yet, in many systems, there's a blame culture in which, if you acknowledge that, it may come back to personal repercussions. And so I think that culture of sort of blame, misreporting to the extent of falsification very much exists. I've seen some very helpful strategies towards this around really building a quality culture, and it takes leadership engagement, it takes honest conversations, it takes time. And I think one of the more key strategies that can help do this is if we stop looking at deaths look at deaths and stillbirths in a continuum. You know, from a pragmatic, practical quality improvement standpoint, it can be very helpful to just remove that from the conversation, because often fundamentally the cause of the death of the baby at 7 days is not very different than the cause of the stillbirth. There may be, I think that just helps people come to the table to have a meaningful discussion. The other big thing I think is for systems around MPDSR and sort of reporting and problem analysis to actually be held at the district level rather than at an individual facility level. I know that there are reasons for this, but I think one of the inadvertent consequences is that the whole process is sort of seen to be owned within the confines of a single facility, when for many of these cases and communities and experiences, it's about drivers that may have happened across many different time points. And when it's separated like that, it sort of promotes a culture of a facility saying that the stillbirth happened because the woman presented late or the community health worker didn't do their job. For the community, for the lower level facility to say the woman didn't get her prompt C-section on time, nobody answered my call. All of these things may be true, but ultimately nothing gets done because it's not seen as a joint accountability.
Totally agree with that, Hema. Thank you. I know we are running very close to the time, but I do want to take this one question. And Hema, again, back to you. You've answered this online, but I'm just going to put two questions together. The question is, we need to think of health of young women before they become pregnant, not wait until the antenatal care. And then there's another question that highlights how many of the mothers are malnourished, and we need to address that as well. So if you could just answer on basically what you said online, would be good to hear.
Sure, absolutely. I mean, the health of young women are critical to society. I mean, this is the whole life cycle. Ultimately, if young women have good nutrition, access to education and opportunities, access to reproductive choice, and are not forced into marriage too young, all of these things are unlocked. And then on a very kind of technical basis, of course, nutrition interventions, MMS started early for anybody of reproductive age. These are all preconception types of interventions to help prevent stillbirths. But I think the larger issue is valuing young women to be more than reproductive agents and for their independent and individual agency and contributions to society.
Thank you, Hema. Over to Paula now for her closing remarks.
Thank you, Raki. Thank you, everyone. What an amazing discussion. I know we could discuss for hours more, but unfortunately we're out of time. I think the highlights from this are the need for good data, the need to create more awareness, but of course to move that awareness on to action. We know what the interventions are, we need to get them done. We know that we need a life cycle approach, as you just said, Hema. Absolutely. We need to start with a healthy girl becoming a healthy adolescent, being a healthy pregnant woman and delivering a healthy baby. So, it's all interrelated. Unfortunately, gender equality is something we're all still struggling with across the world, and that has massive implications for really achieving these objectives. But we don't want to be too negative, even in such a difficult climate and so many crises around the world and funding cuts and all the rest of it. We do need to be optimistic. It is a time to come together to really reform the system and the way that we all operate. Make sure that parents' voices are a critical part of that discussion. The lived experience is just so critical. And we really try to do that in ISA, is to elevate that voice of parents, including fathers and men, but particularly those mothers who have suffered a bereavement. If we don't listen to them, if we don't learn from their experience of poor care, but in a very positive way, in a non-critical, non-judgmental way, we won't improve things. So we've all got a lot to do, and we all need to work very collaboratively together to do that. So thank you to London School for hosting this with us. And please, I give the website of ISA, please look at it, look at our resources and join us. We want more and more people to come together and work together to reduce stillbirths and have healthy mothers and babies. Thank you so much.
Thank you, Paula. Hannah, over to you.
So I'll just add my thanks to everyone for joining today. And as Paula says, please do think about joining International Stillbirth Alliance. Let's work together to end preventable stillbirths and improve care for every woman everywhere. Thank you. Goodbye.
Thank you.